Good afternoon, everyone. On behalf of the Center for Cooperative Media at Montclair State University and my colleagues here, Cassandra Etienne and Joe Amdiris, I welcome you to our press briefing on the growing healthcare affordability crisis in New Jersey. I'm Anthony Advincula, Director of Ethnic and Community Initiatives at the Center. The topic of this briefing, which is part of our Not Your Same Old Sources series, is incredibly timely yet complicated. We anticipate that federal health policy changes could worsen coverage gaps and increase financial strain for working families, individuals with disabilities, and immigrant communities in the state. Data indicate that more than 700,000 New Jerseyans live without health insurance. So thank you to our speakers and moderator who will shed light on this important issue, and to all of you for joining us today. If you have a question during the presentation, please share your name and question in the chat box. So now let's begin the briefing. I will hand it over to Jordan Call, our moderator, who is a reporter for Slice of Culture and a journalism professor at St. Peter's University.
Thank you so much. Truly an honor to be here hosting the 2026 press briefing on the conversation of rising healthcare costs and arranged by the Center for Cooperative Media. Thank you for the speakers that are here and for the members that are participating in this rich, full conversation about healthcare in New Jersey. Just wanted to start off by introducing our panelists. My name is Jordan Cole. As Anthony mentioned, I'm a reporter at Slice of Culture. I also wanted to introduce Dr. Brittany Holland-Truendy. She's the research director at the New Jersey Policy Perspective Think Tank Institute. We also have Linda Schwimmer. She is the president and CEO of the New Jersey Healthcare Quality Institute. And we also have Laura Waddell, who represents the healthcare program as the director for the New Jersey Citizen Action. So we'll get started with the first question. So a lot of the conversation has been, well, we'll start off with some figures and talk about the stake of healthcare now. So under the Congressional Budget Office, 14 million people are projected to lose health insurance in the year of 2034. Those additional costs are also totaling 17 million Americans who will be stripped from Medicaid due to the One Big Beautiful Bill introduced under the Trump administration on July 4th of 2025. In this report as well, we also have another layer to the issue where it's in 2024, for the first time since 2019, you had more people that were actually left uninsured, with the number totaling 1.3 million more people under Kaiser Family Foundation analysis. Again, the numbers, the percentage goes from 9.5 to 9.8%. And again, we're seeing under the Department of Health as well that per person healthcare, there seems to be a 6% increase. So prices are going up, premiums are going up. What does that actually translate into the state of New Jersey? So my first question, and I'll present it to the panelists, is how are these cuts and impacts that we're witnessing in the federal universe translating from members in the underserved community? I believe the number is 727,000, as Anthony mentioned. But yeah, what are those federal cuts and how are they impacting folks that are already uninsured? And whoever would like to start the answer.
I could jump in if you'd like. As far as what are the cuts and how are they being felt in our communities, I do have kind of like a timeline of what people can expect, if that will be helpful for folks. So let me just share my screen really quickly. So I want to say that the timeline of these cuts that folks should be aware of is that starting for New Jersey Family Care Medicaid, starting really this quarter, the first round of communications for about the work requirements to the what's called the ACA Medicaid expansion population are starting to go out to New Jersey family care enrollees. And just to give you context, these are the expansion population are individuals who make a monthly income of between $1,300 and $1,800 per month. They're what they call able-bodied adults who are without children, also adults who are parents of children over the age of 13 years old. So just to keep that context in mind when we talk about this population of folks. And then starting October of this year, there will be restrictions on the definition of qualified immigrant statuses. That's going to result in estimated up to 20,000 New Jersey family care enrollees losing coverage. So the new qualified statuses for New Jersey family care, permanent residents, so folks with green cards who have been here after more than 5 years. There are certain entrants from Cuba and Haiti, migrants from Compact of Free Association, so COFA nations, and some children and pregnant women who are covered under a particular option. So, you know, a lot of the others eligibility statuses will no longer apply. And so want people to be aware of that. And in regards to next year, these work requirements will be starting in January for New Jersey. And so, you know, people will have to prove that they either work 80 hours or that they have been enrolled in school or have volunteered for 80 hours. And this is that Medicaid expansion population, those folks making between $1,300 and $1,800 per year. They're going to have to start having eligibility renewals instead of 12 months. It'll be 6 months, some shortened retroactive coverage period. And then the following October, some copays. They'll have to start paying $35 in copays for their doctor's visits. And there's also impact to marketplace coverage. We've seen rising premiums for us as a navigator organization who help enroll folks in coverage. We've seen egregious cases like 400, 600% premium increases. And this has, as we just saw yesterday, we're seeing a decrease of 70,000 folks on our ACA Get Covered marketplace. And so this November, the enrollment period will be shortened as well. So it'll be November and December, and there'll be some new income verification changes also. There's some changes in Medicare that folks should be aware of in regards to negotiating prescription drug prices, and starting this year as well as next year in July, changes in immigrant eligibility. So just wanted to flag some of those unfortunate changes.
Can I jump in here as well? So I wanted to kind of build off of what Laura just showed us with all of the details of what's happening. Essentially, you know, the U.S. healthcare system is it's a non-system system, right? It's a combination of programs with different priorities rather than like an aligned national system with different branches. So what we're seeing with affordability is that essentially it can be attacked and degraded from all sorts of different angles. And that's exactly what Laura just kind of laid out there, of these different effects of HR1 in particular. But in combination, if we're talking about affordability broadly, this is in combination with things like the long-term effects of the COVID-19 pandemic and other, policy actions and such that all kind of build on each other and really pick at the healthcare system and at affordability in different ways. So what Laura laid out with these different changes, even just again from HR1, of these different changes in programs. There's Medicaid and Medicare and CHIP and immigrant eligibility just for a wide variety of programs. There's all of these different things are affecting affordability for not only those populations but for the states, for residents of all of the states, right? So essentially we have two parallel challenges of affordability happening here. We have affordability for residents, and so like having coverage, what those copays are, like whether that coverage is adequate, just that piece of things. And then you have affordability and rising costs through the lens of state budgets. And that's what my organization works on a lot. We're Think and Do Tank, we're focusing on policies, and our bread and butter is tax and budget. And, in looking at the losses through these cuts that Laura just laid out of, the expected losses in Medicaid due to these work requirements and due to the increased frequency of redeterminations, you're going to have losses in enrollment, which means fewer federal dollars supporting coverage in the state. People are going to become uninsured, and then that affects health outcomes, and in turn also affects what the state is having to pay for through like charity care and other services to help address people's health issues when they don't have coverage. The reductions in the enhanced premium tax credits that were mentioned, these again also it's reducing the number of federal dollars that are coming down to the state. It's leaving this gap. So the state, even as they're providing support for subsidies, they can't cover everything right now. So there's a big gap, and people are having to pay more. And so the state budget, the policymakers are having to decide, can we fill that gap? And the answer is likely not fully. These are huge cuts that are coming down from the federal government. And so there's just it in turn, it creates a crisis for the state budget, but then creates the crisis for residents as the state cannot absorb these cuts and changes. This is in addition to a variety of changes in like provider funding that are happening as well. Again, like I said, it builds on already rising costs and the effects of things like the historical pandemic we just experienced a few years ago, and what care people need. And, in an already like an aging population where you were seeing care changes, types of care needed changing, you're also seeing, again, the effects of chronic illnesses and things that happened during the pandemic. So there's just a number of things that it's again this parallel crisis of for residents. You're seeing increased costs day to day, can maybe not afford a plan. The state, in trying to address the cuts coming down from a federal government whose priorities, political priorities and such, have changed, and support where we thought there would be support just no longer exists, right? And the eligibility for immigrant populations, for example, is being cut, and there's just all these changes that we didn't think would necessarily happen when we saw how well parts of the ACA really helped people get coverage. So there's just like a number of things happening with these two challenges between residents and the state, and just this kind of perfect storm of the crisis of these billions of dollars in cuts that are coming down from federal policies.
Doctor, thank you so much for those insights. Linda, yeah, if you'd like to, wanted to see if folks can do like a little brief introduction for the ones that are tuned in, and then, yeah, if you'd like to weigh in on Dr. Churundi's findings.
Sure. Thank you, everyone. Hello. Good afternoon. Thank you for having me. I'm Linda Schwimmer, President and CEO of the New Jersey Healthcare Quality Institute. And for any of you who I haven't met yet, it's a pleasure to meet you. The Quality Institute has been around for about 28 years. We're a nonprofit, nonpartisan organization focused on improving healthcare quality, safety, and affordability for everyone here in New Jersey. So very, very pertinent topic today. And we are part of the Healthcare Coalition that Laura mentioned that her organization runs, and we work very closely with Brittany and her team. They're a member of ours, working on healthcare affordability and budget-related issues in particular. I wanted to just piggyback off of what Laura and Brittany were just talking about. At the Quality Institute, we do a lot of policy work. We look at systems and programs in particular that the state runs, and we work on ways to improve those systems for people here in New Jersey. And so just taking a step back and looking at the ACA market, or the Affordable Care Market, there was just a press release from Dobie yesterday explaining that because of the premium tax increase that happened during COVID not being extended again, we lost 14% of the market. So when you think about, there's about 500,000 people that buy their own insurance and they're enrolled in that market. That is a market of last resort. It's a place where you can get insurance no matter what. There's no medical underwriting. And as long as you're a resident of New Jersey, you can purchase insurance. And for all of the reasons that were stated, insurance premiums without that subsidy are very, very expensive, which is why once that premium subsidy went away, we declined by 14% in terms of the number of people in that market. What that's going to mean for next year is that it's going to be even worse, because the people who were sicker and absolutely needed insurance found a way, they balanced their priorities and they got that insurance. The people who were healthy did not, or healthier, did and couldn't find a way, did not. They prioritized other things. And that is a recipe for disaster when it comes to insurance markets. That's what's called adverse selection. It's the exact same parallel type of behavior that we're seeing in our state health benefit program, where groups are leaving that market and going to other markets and making decisions based on adverse selection. And it just makes the situation worse. So, as you're thinking about covering stories in terms of trends and insurance, I think this is a trend that we've been seeing for a long time in New Jersey, unfortunately, that there's a lot of decisions and changes and things we could be doing that would make our insurance markets healthier, whether it's the state health benefit program, or whether now it's the individual market or the small employer market, which is even in worse shape. All three of us could answer and discuss a lot of those issues. And those are really important issues for the media to cover, because unless these steps are taken before it continues to get worse, it really then starts to compound, and it gets worse and worse. And so would love to talk about that. The other thing that Laura raised, and I really loved her timeline, is just the scale of what's going to happen and what we're facing. The OBA was a very intentional way to cut off federal dollars and to use those for something else, mostly tax rebates to other people, and to make the state pay more of the bill for healthcare costs. And so New Jersey is looking at losing anywhere from $3 to $6 billion in funding over the next few years for healthcare costs. We are definitely going to be covering a lot less people. Laura laid out what's going to happen just this year for certain immigrant populations. They are no longer going to be eligible for coverage. There's other changes that are happening with the Cover All Kids program, which is a coverage for kids that is regardless of their immigration status. That program is in jeopardy. That's about 45,000 children. And all of the other hurdles that she mentioned, those are hurdles that are put there. And what that means is that people are less likely to get in or successfully enroll in Medicaid. They'll fall off the rolls. And just to add another thing to what she was saying, if you fall off, but you were eligible, you're not allowed to come back in for 6 months, and you're not allowed to enroll in the individual market either for a premium support. So it's a really, frankly, a draconian, or punishing program that's being set up with the intention to reduce federal funding of healthcare and to make it harder for people to be enrolled in Medicaid. And we didn't even talk about SNAP, but SNAP, those changes start this October. Again, that's an essential program, and it's going to have not exactly the same, but almost identical, very same hurdles for people. So it's really important that the media is explaining all of this, that you're partners with community organizations like ours to get the word out. And I appreciate that people are interested in this today, and happy to continue to answer any questions.
Thank you for that, Linda. And is there someone? Sorry there. But yeah, so this definitely, and thank you so much for those insights. And I believe it paints and the story speaks to a much more bigger picture when it comes to the healthcare landscape. A lot of these strains and challenges that we're seeing seem to be coming from the federal grant cuts. But you mentioned a lot of these cuts are, a lot of these policies are being reshaped in real time. Medicaid coverage rates dropped in 22 states for children under 19 and in 33 states for ages 19 to 64. So that influx that you're mentioning is pretty much being seen in a lot of the granular from the states. But yeah, I guess I wanted to talk, we have a room of reporters and members of the press, and one thing I was thinking about is how healthcare aligns with a lot of like fundamental human rights, right? The access to it. A lot of these pathways and connections, they're inherently linked. A good, proper healthcare infrastructure, deals with more societal quality of life improves, long-term jobs, workforce is also all integrated in this. But one of the things, and I've been recently covering a lot of the, University Heights Hospital, formerly known as Christ Hospital, and a closure that we're seeing in Hudson County, of one less hospital in Hudson County. And again, I wanted to talk a little bit about, in talking to a lot of the medical folks in the field, they're saying that, a lot of these cuts are leading to some of the biggest cuts to the social net, like the social net that is healthcare in their history, right? And I think Dr. Trundi's, your report on the recent report on New Jersey policy perspective, Mind the Gap, keeping New Jerseyans covered in the face of federal cuts, I think explains a lot of the repercussions, right? Members that are being stripped, that are working class people, medical debt are increased, putting families into essentially a state of crisis. I think I would love to quote the part where you mentioned that, quote, contradicting the hard-won lessons of the COVID-19 pandemic. So I don't know if you'd like to expand on that report, on that recent report you just put out, showing the impact of a lot of these federal cuts when it comes to New Jersey, the state of New Jersey.
Sure. So during the pandemic, we saw a suspension of things like the redeterminations that they're now trying to make happen every 6 months. We saw people not being disenrolled just due to a lack of needed paperwork or something like that for a longer period of time. And we learned that it actually kept more people covered. Like we saw the effects that we had better coverage. We didn't see the churn that we often see in Medicaid, where people are becoming ineligible and then they're coming back on later. And so we learned a lot of lessons during the pandemic about what keeps people covered. And these federal actions are specifically taking a lot of the, not just reversing, which we had already started to do with the Medicaid unwinding, not just reversing some of those, but also like taking it further, as Laura and Linda both laid out, that it's essentially framing healthcare not as a human right, as you were just saying, but more as like a benefit to be earned. That not everybody is qualified or deserving essentially of healthcare. And so that's the framework, that's the mindset essentially that's surrounding all of these cuts. This idea that, again, the federal government at this point does not want to pay for, it wants to pay for less than they had been. But also, yeah, again, is essentially prioritizing who gets that benefit. And again, this goes back to pre-ACA days. It goes back to framing that we haven't seen in a while, because we had, again, seen through the ACA and through those lessons during the pandemic of what keeps people covered. And like Linda said, there's this issue within healthcare economics of the narrower and narrower you have of a pool of people who are covered, the prices can go up. It can have all these adverse effects. You want everybody covered. It helps health outcomes. It helps to spread out the costs. It helps, like, having that stability keeps people healthier and improves the healthcare system overall. And so that's where, again, the cuts that are happening right now are exactly opposite of that, and something that the state needs to work on. I'm seeing lots of questions in the chat, for example, about immigrant eligibility and what can be done. And that's where, again, the state has not fully built out. We have Cover All Kids, which has been a great advancement forward of getting more residents covered, but has not yet built a broader system of alternative coverage or an ability for people, like, filling in those gaps that are being left, that is more stable over the long run. I'll leave it there for now, but I'm sure I could add more.
No, thank you for your insights, because it's definitely draconian method, draconian timelines, right? Healthcare timelines. So yeah, I'm going to start reading some of the questions in the chat. I'll start with Anthony Orlando from the New Jersey Urban News. And again, it's part of the conversation of where the state's budget is going and what those trickle-down effects look like. So the question is, do you think that Governor Sherrill's budget proposal for the next fiscal year will be enough to alleviate federal funding cuts to Medicaid, and why? I believe the budget is $60.7 billion, and the Medicaid programs are reaching costs of over $770 million. So I don't know if there's anybody that would like to take on the question on the states. Yep.
I can start as the tax and budget organization. The simple answer is no. These are just too large of cuts for there to be a simple solution here. The budget, they are putting money and effort into trying to improve systems and trying to keep people enrolled as much as possible, because that's going to be a big part of this. So a lot of the cuts that the funding cuts and such that are being talked about are loss of those federal matching dollars. And so keeping people enrolled will help to alleviate a little bit of that. It will both help people with coverage, help their affordability, and help the state keep federal dollars coming in. But the reality is, it's not going to be able to stop it all. And it's going to, the restrictions on immigrant eligibility are going to cut coverage that they simply can't. They simply are not allowed. So without more options that the state builds, it simply won't completely contradict the federal cuts coming down.
I would just add to what Brittany said. Looking at it another way, not necessarily whether the budget is enough, but looking at how we're spending those dollars. I think that we're going to have to look at how we finance healthcare differently than we do today. over the next few years, at least, no matter what, we are going to have, unfortunately, a larger number of people that are just not going to be eligible for either Medicaid or insurance premium subsidies, which means that they're most likely going to be uninsured. And the worst thing would be just to leave it at that and to leave those people on their own. The second worst thing would be if people are seeking primary and preventive care or ongoing, management of their chronic diseases in emergency departments. That's like the most expensive spot to get care and the least effective, and certainly not the most patient-centered and humane either. So we're going to have to look to other services and other models. There's 5 free clinics in the state, and some of this is described in the materials that we shared in advance of this call, and we can share more materials, but we're working with those 5 free clinics. There's also the federally qualified health centers, there's hospital clinics. We're really going to have to look at how do we increase their capacity? How do we get them funding, whether it's state funding, whether it's foundation funding, other charities, but really starting to think about building out ongoing primary care as well as management for more people with more acute care needs over the next few years. It's not a perfect solution. It's not as good as having people being covered, but it's absolutely better than neglecting people or having people go to the emergency room. So that's a huge focus area for us and other organizations across the state.
Thank you for that, Linda. I'll go with the second question. This is coming from Asada Wright from the Jersey City Times. Before the ACA, healthcare funding was the #1 reason why people filed for bankruptcy. When can we expect to see some of those secondary economic repercussions to become evident? Whoever would like to answer that one. You want me to repeat it? I can repeat it as well.
No, I think
just in case.
I haven't looked at the bankruptcy numbers, but I would expect to see more personal bankruptcies with the affordability of everything going up along with healthcare and housing. The other thing I would say on that is we used to have a Consumer Finance Protection Bureau that was doing great work at the federal level to ban credit ratings from having medical bills on people's credit reports. I think that's an area where New Jersey Division of Consumer Affairs and the Attorney General's office in general can really step up and be more aggressive in terms of protecting New Jersey residents. Most of those medical bills, by the time they go to judgment, are honestly crap. I mean, if they had gone to court and had to prove the validity of the amount that was being billed, nearly all of them would be unable to do so. They never really should make it onto a credit report. So making sure that that's done in New Jersey and at least protecting New Jersey residents would at least be a helpful step in terms of protecting people's credit, which, as you all know, it increases, how much they pay for car insurance and mortgages and their ability to get jobs. It's really a harmful thing, and we should stop it here in New Jersey. That's my soapbox for the day.
And can I also piggyback on that? And just, I put in the chat that the coalition launched last year a website, a resource for New Jerseyans, endmeddebtnj.org. It is the only resource in the state, statewide resource that has all of the protections that New Jerseyans have in regards to medical debt, medical billing. If you are unfortunately having to go to court and having to navigate that process, it provides even examples of like legal answers and things like that. It has just a wealth of information, and so just letting you all know about that, and hopefully this will continue to help more New Jerseyans, because as Linda said, medical debt is going to increase because of all these folks who are being dropped from coverage because of all these cuts and the new policies. And it's, New Jersey started out, I think, with about 1.5 million people with medical debt a couple years ago. And I can't imagine the exponential growth of that number because of all of this. So, yeah.
Thank you for that, Laura. We'll make our way to the next question. I have some folks here. I think we addressed this earlier, but Mark Tyler, Atlantic City Focus. What practical solutions are you exploring to work around some of the upcoming changes? Is there a pivot towards philanthropy to close some of the financial gaps? I believe we were hinting at some of the alternatives, but if anybody wants to talk about some tangible forms of alleviating some of the structural health deficits and economic deficits. Yeah.
I'd like to start off, if I could. I think this is an opportunity for New Jersey to rewrite the future of healthcare. Just kind of what Linda was saying is we need to start thinking about how we deliver care and what our public health system looks like. And I think that when we, think about healthcare, we have to think about, what it is that we're actually wanting. We really want whoever needs healthcare to be able to access it whenever they need it and at a price they can afford. So we really should be focusing on affordability. We have to focus on lowering costs and price. We need to think about choice. We also have to think through, coverage and those coverage options. We need to make it simple because it's really hard for people to navigate this system, and especially now that all of these new rules are being implemented. And I think we think that when we talk about affordability, let's just say one, because I know I did see it in the chat, the highest cost is our, hospital prices. But number two is prescription drug prices. And so we have to remember when we are talking about these two, of healthcare affordability, we really need to make sure that we're remembering what those large cost drivers are. And I think, too, it's important to remember that New Jersey does have two mechanisms, at least already implemented in the state, that have been created to look at and take action at just this. And that is the Office of Healthcare Affordability and Transparency. It's the reason why, Jordan, you were able to present some of the trends in New Jersey in regards to healthcare, the rising cost of healthcare, and also the Prescription Drug Affordability Council. And the council, was created to protect New Jerseyans from the rising cost of prescription drugs and to study the pharmaceutical system and create recommendations for the administration and the legislature on how to bring down the cost of prescription drugs. So we need to make sure that those things are stable, that they get strengthened, because there's more you know, we certainly need to have some enforcement around the policies that they can create and recommend. And so, you know, those are just some things that New Jersey already has that we need to make sure we protect, and we need to make sure that they are strengthened as well. And then I also think we need to create some additional coverage options for folks, especially who are being termed, and recapture as many of those individuals as we can. You know, New Jersey can follow suit with some other states and establish a basic health plan for our residents who are uninsured or becoming uninsured, who are making up to 200% of the federal poverty level. We have a pathway to establish a buy-in program, public option. So there's a lot of things that New Jersey can and should be looking forward to doing. So I just wanted to kind of get some of that into.
Yeah, and can I just kind of jump in here too, that to say that, you know, mention of philanthropy, like there are things that address a gap in a moment, in that in an immediate term, maybe this can help fill some of those dollars. But as my fellow panelists have been mentioning, that's just not sustainable. We can't keep addressing the healthcare system with a Band-Aid here and a Band-Aid there. It has to be a restructuring and rethinking of something that is sustainable, where you're eliminating loopholes, where it's not going to, you know, you're not going to have an issue with funding in a whim in any particular year, and you're creating a system that it can again absorb shocks like the pandemic and like these other changes that we see. You know, there's constant talk about you know, new pharmaceuticals, new this, new that, and it's like that's just how healthcare is going to work. So you need to have a system that can adapt and go with what changes are needed in care.
Yeah, I think there's a role for philanthropy if you're trying to test a pilot or launch something just at the beginning. And we are working to try to get both philanthropy and hospital systems to help support, expand, or set up new free clinics to meet this rising demand. But I agree with what Brittany just said. At the end of the day, you do need a sustainable structural change in just where those healthcare dollars flow. Our state budget is it's unbelievable that it's at 60 billion now. I mean, that's a very large number compared to what it was just 5-6 years ago. But looking at where that dollar is going, it's not always about increasing, it's about more effectively spending it. And I think that's really what we need to be doing.
Thank you for that. We'll segue into the next question because we're 2:44, so we just want to be mindful with the time. Mashin Zahir from Urdu News asks the following question. What specific policy steps can be taken to ensure that immigrant communities, including those facing language barriers and limited access to employer-based insurance, are not pushed further into medical debt or forced to delay essential care? Think that talks a little bit more into like the work labor compliance aspect to it.
So you know, one of the policy ideas that I just spoke about, the a buy-in program, that is something that the coalition has been prioritizing since the passage, actually, of the legislation that brought about Cover All Kids. And within that statute, within that legislation, there is language that creates a pathway for the buy-in to, the idea was, the intent was, now that we have expanded coverage to all children, regardless of immigration status, let's now create a pathway for their parents and so forth, and to be able to build on that. And so I think that buy-in, and New Jersey Family Care, like buy-in type program, would be an opportunity to be able to present healthcare that is, or health coverage that has some subsidies, that would allow for our immigrant population to be able to access. That I say that, and also know that you also have to think about it and consider, funding and revenue raising to be able to fund those subsidies. So that's very much a part of the discussion, and there are some ideas that the coalition has for that, but so that's just one of the ideas that we have. Of course, luckily we do still have our Cover All Kids. So
Okay. Anybody? Okay. Well, yeah, Linda, saw you there.
I wanted to, if it's okay, I think it's an interesting question, and I wanted to respond to it. It was Ashanta Wright of the Jersey City Times. From a story framing standpoint, how can we frame our healthcare stories so that people who are relatively well off and insured give a damn? Talking about Medicare funding, Medicaid funding, immigrant care, et cetera, won't move the needle for a lot of my readers. Is it okay if I respond to that? Hello?
I was supposed to ask it, but by all means, yes, by all means.
The reason why I think it's an interesting question, because I think that this is the conundrum, right? Like why should other people care about other people? And I think, like it or not, we're all impacted by this. If you look at where your tax dollars are going, those wealthy Jersey City people, probably most of them are going to their real estate. I mean, besides the state income taxes, they're going to municipalities that get a lot of municipal aid. And they get a lot of municipal aid to cover all of their services, particularly schools and municipal services. And the largest cost for schools and municipal services, besides salary, is healthcare. And if you look at the other big costs they're probably spending, it's property taxes. And where is that going? A lot of that is going to healthcare costs. A lot of our tax dollars go to charity care, which are these large hospital systems which pay for some of its uncompensated care. So all of these things, whether you're an employer, if you're an employer and you're a wealthy employer in Jersey City, you already know that when you're looking at your budget, besides payroll, a lot of your spending is going to healthcare costs. So thinking about these issues in the full context, and how do we address healthcare, pay for it, and make it more affordable, is really all relevant to all of us. It's not just siloed by, how wealthy a person is. We're all paying for it in one way or another. So this is hard to explain, I know, in a short piece, but reaching out to people like me or Laura or Brittany, I mean, we can kind of help you talk through stories. But I mean, fixing these healthcare issues is really how we make New Jersey a more affordable, also just more accessible human place to live for everybody. This is why people, say they want to move someplace else. They'll move to a state that probably doesn't have as good as schools, or as good quality of a healthcare system. and but it costs less. So it all is related. I don't know if Laura or Brittany have other thoughts on it, but
Yeah.
that's how I would explain some of it.
Exactly. And I also like to say, like, I know that, we lead with the cuts to Medicaid, the cuts to the ACA, but all of it is impacting employer coverage. I don't know, anyone who did not have an increase in their healthcare health coverage premiums. So this is happening. Yes, the Medicaid and Medicare and ACA cuts, are the most recent, but the trend, of the rising costs in healthcare, that's been happening. That's been year over year. And so, yes, we have Medicaid, Medicare, and ACA rises and cuts and things, but also employer plans have been very much impacted by the trend of the rising costs and prices and premiums in health coverage as well. So it's affecting everybody.
Yeah, and I'll sorry, add one more thing that, as my fellow panelists have said, like everything in healthcare is connected to everything else, essentially. We, again, with public health stuff, we saw this with the pandemic. When people get sick, don't have coverage, aren't going to hospitals, aren't going to get care, then other people are getting sick. Like there's everything has a knock-on effect. And it's the same as my fellow panelists have said with plans and affordability of coverage. It's the same with facilities being open. I mean, the biggest thing about rural areas is that not only is there's few people, and then you can't keep a facility open. There's not enough patients. That people don't have, some people don't have coverage. It becomes difficult to even keep a facility open if you have fewer and fewer people with coverage, fewer and fewer people seeking care. So there's just so many knock-on effects. Everything is connected, and that, like, to think that you live in a complete silo in a healthcare system is just it's just incorrect. So helping readers to understand that and understand how all these prices and how all these systems work together, I think is really key.
Yeah, and look at those cost drivers. Like, look at what is driving up the cost of care. That's where you get into, okay, the top cost driver was hospital prices. The number 2 cost driver was prescription drug prices. The number 3, the number 4. So that's another way to, spread it and make it so that everybody can access this sort of story and experience.
No, thank you for that. And I had a question, and I'm moderating, but I definitely want to chime in with a question. But as reporters, right, we work in the information space, and there's a lot of like connections here inherently. We struggle from like local news deserts, right, where there's a certain population or a certain demographic that no longer has access to streams of information. I'm sure that could be paralleled to healthcare deserts, right? And that's what they're calling it. A lot of the healthcare desert aspect. Is there parallelisms between, a healthy information space and then, a healthy healthcare infrastructure system? Do you see those playing hand to hand? How is that collaboration being seen in today's healthcare landscape when it comes to collaborating with the reporters? And, I think about the times that I have to take care of HR and in terms of like going back and forth and getting these framework, like responses. But again, what is the actual collaboration in terms of actual journalists getting the right information right in terms of hospitals?
Well, I'll just start just in general with the healthcare reporters and the ecosystem. I mean, unfortunately, just like healthcare systems have been under attack, media, particularly public media, has been under attack. But my organization has a really close working relationship with the healthcare media. We really value you and your ability to tell a story and connect with people, and welcome that partnership, because I know that this is really complicated stuff, and we need the media to help us translate it and make it meaningful and then actionable. We put out a lot of reports and we have a lot of suggestions of things that need to get done. And we're kind of like Brittany said, they're a think do tank. I mean, similar, like I am not interested in putting things out just for the sake of it. We are not an academic institution. We are focused on doing research and putting things out so that we can change things and make them better. And we can't do that without the media. So we greatly appreciate the opportunity to partner with you to make a difference. And speaking of that, I put a report in the chat on primary care. So I hope that you will read it. And well, it's actually not a report. It's a sort of a policy piece, but it links to a report. And we'd love to talk about that with anyone who's interested.
Awesome. I believe we have one more question that I'll mention it. So yeah, we have a question coming from Mira Carmen Amado with New Jersey Hispano newspaper. The question is, the state stands to lose more than $3 billion by 2027. Does the state have a contingency plan in place to cover this financial shortfall and prevent thousands of people from being left without medical services? I could repeat the question if you guys like.
So I believe that number is tied to the loss of enrollment in Medicaid, because as I think Linda mentioned before, and maybe Laura did too, the total funding loss is 3 to 6 billion when you include other types of funding losses. So this is just tied to the loss of enrollment and the loss of the matching funds in Medicaid. And so the contingency plan, I mean, basically we lose that funding if people are not enrolled. So the plan for that particular aspect is to try to keep people enrolled, and that's where they are putting some funding into improving the systems and trying to help people stay enrolled as easily as possible. But again, the federal rule changes are making it like specifically designed to make it harder to stay enrolled. So they're doing what they can, but it's not oh, we can just fill in that gap and keep people enrolled. It's that people are going to actually lose their eligibility and lose enrollment. And that's where the federal dollars are not going to be coming in.
Yeah, anybody else want to weigh in on that question?
The only thing, I
Yeah.
mean, it's, exactly what Brittany was saying is that, the state has communicated that it is trying to work on all options that will hope to lessen this spread, lessen the impact of all of these cuts and lessen the amount of people who are being termed because of it. And so that's what they're doing. And they're, doing a number of looking in and working on a number of ways in which to do that.
Yeah, and I think a key part here, and again, this is for the importance of the role of the media, is that a lot of people I think don't understand what's coming, like don't understand the eligibility changes that are coming, the changes in the work requirements, the changes in the reporting that's going to happen, and so again, a big part of a really important part is getting that information out there more and talking to people, because I know as far as our work at least, hearing people's story, like a lot of people have a really hard time conceptualizing a healthcare system and how things are affecting people or what exactly it means. So hearing those stories from folks is that are affected or who may be affected are really important, because again, with the work requirements, for example, people can dismiss it as, oh, well, people just need to, there's exemptions. So if you just fill in the paperwork, if you have a disability, you won't be subject to that. There's a lot of actual barriers that stop someone from getting that paperwork done, where it's like they would be eligible. They can't get through that red tape. And so hearing those stories, connecting all of that is a really, really important part for the media, and really getting that information out there of what's happening.
Well, I believe we've reached our 3 p.m. mark. Thank you guys so much for an incredibly fruitful, engaging conversation. And yeah, hopefully we'll be back reporting more on the media healthcare landscape. But yeah, no, thank you guys so much for those who attended. I don't know if there's anybody else I'd like to conclude with.
Yeah, so we just want to thank everyone, the speakers and the moderator, Jordan Call, and our ethnic and community media partners. Thank you. A recording of the briefing will be sent to all the attendees. So thanks, everyone.